With one exception, Professor David has conflicting further duties, and he's going to leave after a short discussion session. So let us welcome the first presentation, Dr. Bottari from Italy. She's going to talk about the extracorporeal blood purification in septic shock. Thank you very much.
Thank you, Mr. Chairman, dear colleagues, good morning. First of all, thank you to Professor Vanzana and Professor Taccone for this kind invitation. I have no conflict of interest to declare. Talking about extracorporeal blood purification in septic shock, we cannot ignore what some authors have observed about the last scientific evidence in septic shock. That is the concept that despite an improvement in understanding of pathophysiological mechanisms in septic shock, a large number of randomized control trials failed to show an improvement in survival. So, from this point of view, we should reassess also the topic of extracorporeal blood purification in septic shock. In particular, reanalyzing some important key points: intervention, population, and outcome. Regarding intervention, first of all, techniques. Extracorporeal blood purification techniques include many types of techniques, and we cannot compare orange and pear. The techniques in extracorporeal blood purification are different from a different point of view. Mechanism of action, indication, target molecules, and in the way in which we deliver the technique. And a deep understanding of this mechanism behind the technique is important to develop a critical price of scientific literature exciting on this topic. Inside the same technique, there are also differences. If you think to the adsorbent column, chemical and physical characteristic of this device can have an impact on efficacy. For example, the pore size can have an impact on efficacy of inflammatory removal of mediator. And the same is for the plasma exchange. We have centrifugal plasma exchange and a membrane plasma exchange, and these two modalities are not the same. In fact, the study have shown as plasma removal efficiency is different in the two modalities, and the cutoff point to remove molecular is different. The second point is the timing. Today, we know that after the infection insert, we have both a pro-inflammatory and anti-inflammatory reaction. But this reaction changing among the patients and inside the same patient during the course of the critical illness. So it's very important to know when we have to deliver the blood purification. On the right, we have just an example of an early approach to manage the cytokine storm and to prevent the organ damage associated, and also to prevent the immunoparalysis associated to sepsis that is correlated to a high mortality in septic shock. The third point, most important, is about the doses. Today, we have to start to talk of doses also in blood purification, as for the drugs. The doses is very important for the impact on the result of our study. And this is an important example, is a randomized control trial in which the author ever uses cytosorbent hemoperfusion by session of 6 hours. But today, we know that this device works on duration and number of cartridge. And so if we cannot deliver in the right way the treatment, of course we have an impact on our result. And this is another most recent study. The author have selected a population with very high level of IL-6, but they have delivered the treatment for only a median of only 9 hours. That is too short, is the opposite of the concept of the mechanism of action of this device. And this is the same for this old study, but very important in pediatric critical case about therapeutic plasma exchange. The author used both centrifugal and membrane plasma exchange in a clinical picture of pediatric septic shock associated to piastrinopenia, associated to multi-organ failure. But we know that one of the most important target mediators in this clinical setting is von Willebrand factor that have a very large molecular weight, and the membrane plasma exchange can have an impact on these molecules. Population. In many disciplines, is recognized the concept to select the population with a biomarker or cytokines. And this is the story of the polemic CMB. A large number of trials failed to show an improvement in survival. The last one, the Euphrates, did not show an improvement in the survival at 28 days. But following an post-hoc analysis evidenced as in a subgroup of patients with endotoxin activity between 0.6 and 0.9, there is an improvement in survival. So the concept to select the right population, and this is another example of a randomized control trial with a very high heterogeneity in the population. In this study, the author have included patients with sepsis and ARDS septic shock. So high heterogeneity has an impact on our result. So the future could be to select our population. With what we have in this moment, biomarkers, damage-associated molecular factors, cytokine, and in the future, we talk a lot in this day, clinical phenotype and endotype. Mortality. This is another important point regarding this topic. Mortality is the most common endpoint in the study about extracorporeal blood purification. But we know today that also for mortality there is a high heterogeneity in the sepsis population. Furthermore, if you consider population with very low mortality as control group, it's very difficult that you are able to show a further improvement in survival. So it's very important to move from alternative endpoint. The example of the International Cytosorb Registry, in which the final results evidenced a very high mortality expected and observed, higher than what was observed in previous study and systematic review. And this can suggest a selection of course, most sick patients. So the importance to move also to alternative endpoint in extracorporeal blood purification that can reflect the pathophysiological background, our experience, observation, and physiology. Very important, the last point, the safety. When we use this technique, we should be able to manage the antibiotics, the antimicrobic therapy. So it's very important to know very well the technique, the characteristic pharmacokinetics of antibiotic, the characteristic of the patient. So it suggested when it's not available therapeutic drug monitoring to use a multimodal approach based on the drug properties, on the PK characteristics of the drugs, on the characteristics of the patients, of course. In conclusion, what we should do is what Thomas Kuhn defined a paradigm shift, to move from normal science to an extraordinary research to adopt a new paradigm. I have concluded. Thank you for your attention.
Thank you for this wonderful and enlightening presentation, clear overview.
Next up, we'll be talking about plasma exchange and septic shock with Professor Sascha David.
Good morning. Thank you very much. This was a very beautiful introduction, and I will pick now one of these technologies that you've heard about that I am kind of fascinated from, and I believe that it could make a difference. So this is plasma exchange. And the reason why we're doing this is because we want to treat the host response. So this is what sepsis actually makes of. If you look at the armamentarium that we have available, there is focus eradication, anti-infectives, so treatments of the infection. We have the supportive therapy, treatments of the organ failure, but what we actually do not have is a modulation of the host response. So what would be an ideal specific treatment against sepsis or septic shock? So why are we a little bit lost in translation? And I think it's because the mouse models did not really translate very well into the humans. If I would be a mouse, there would be 100 ways to cure me from sepsis, right? So it doesn't really help. That's just an example for a ton of pathways that have been tested in mouse that really worked nicely, that completely failed in humans. And the reason for this is the complexity of the immune system. Most of these trials are focused on the modulation of this, and it's non-linear, and it's really hard to monitor in a dynamic fashion. So if these illustrated, really simplified schemes are a little bit true, you can imagine that dependent on where your patient is at a given time, a treatment might help him or it might actually harm him. So it really depends if we can monitor the situation of the immune system. We simply cannot. But the host response is a little bit more than just the immune reaction. So there's interaction with the coagulation system. We all know this from the bedside. DIC, a very traumatic feature, and there's endothelial dysfunction. And I picked the endothelial dysfunction because I think it has a really central role here as an example for how organ failure develops. We know there's massive permeability, there's vascular leakage, there's intravascular activation of the coagulation, and there's local inflammation. So the endothelium expresses adhesion molecules to recruit leukocytes. A good thing if I have a pneumonia and it only occurs in my upper lobe where the pneumonia is, but the bad thing if it happens everywhere. So this leads to hypoperfusion on the organ level. At the same time, the endothelium releases nitric oxide, the strongest vasodilator, and this leads to distributive shock. Altogether, making the pathophysiological features of organ failure. So you can see that there are two sides of this, a macrovascular and a microvascular feature. And if you just look at the videos from the microcirculation of 2 exemplary patients, and you've seen these videos all over the conference now in much nicer quality than I have them, but I just want to make the point how this microcirculation is actually altered in the disease. We have to try to find a way to start the videos, though, which I have to apologize. I tried this earlier, but it doesn't work. Do you have a way you can click on something? Because I can't. Okay, so I explain you what you should see. It's a pity because it's really a traumatic. Now it starts. So this is a patient on low-dose vasopressor with a pancreatitis, not in shock, and you can see under the tongue how the microcirculation would look like if it's more or less intact. And that's a patient in severe septic shock. It's an extreme example that I've picked, where you can literally see that there's not a single erythrocyte moving anymore. Although, if you look at the mean arterial pressure and heart rate, it doesn't look so traumatic. But under the tongue, and this patient, fair enough, was also mottled. There was also bad refill time. All these tests that we know of at the bedside, they are all applied. It's just to make the point for you visual what actually occurs in the microcirculation. And the reason for this is the leakage, so the sludging phenomenon, and it's also the activation of the coagulation in the very small vessels. And that's something that is well known in other diseases as microangiopathy. And I show you an example because that's something that's potentially modifiable using plasma exchange. We all know that the von Willebrand factor is a very large protein, it's extremely sticky, and it's stored in the endothelium. So if I cut myself in the finger, it can be released, it attracts thrombocytes, and the bleeding is stopped. But it's so large that it would clot my vessel. So that this is not happening, we have a small enzyme, the Adams-TIR13, that cleaves it into small pieces. So I'm not bleeding anymore, but there's still perfusion. And this is the hallmark of TTP, a disease where the Adams-TIR13 enzyme is lacking. You might know this. And if you now look at septic shock patients, the tip of the iceberg, really, really bad ones, you see that the von Willebrand factor, the sticky protein, is massively released in the circulation, and at the same time, the disease somehow consumes the protease that should chop this into small pieces. So we have a disbalance, everything is sticky, and we don't have perfusion in the microcirculation. So that's the rationale why I think plasma exchange could be something interesting, because we are not just removing, sorry for the German slide, we are not just removing injurious molecules, we are also replacing protective ones that are probably consumed by the disease process. So it's one procedure, but two strategies, if you want so. And I think the replacement is not less important. And we've heard about the technology. It's an extracorporeal circuit where we separate the cellular components from the plasma, we discharge the plasma, we resuspend the cellular components in fresh plasma that contains all the normal proteins, and then it goes back into the patient. And we have some data on the technology in terms of randomized data, and it's almost 10 years old from Canada, from Emily, who found 4 RCTs, 2 of them in children, 2 of them in adults. And if you look at the results, they're very old, they're over 20 years old now. It's a little bit in favor for plasma exchange, but it's low numbers and it's very old. So a couple of years ago, I thought we should increase the evidence for this, because we used it sometimes anecdotally and we saw extremely positive effects, and sometimes we didn't see any effect at all. So we applied for a large grant to test this, and we didn't get the money, but we were asked to do a feasibility trial. And this is what we did. We included patient septic shock very early, and with a very high dose of vasopressor. You can see you have to screen some 300 to get at the end about 20 patients. So it's 10% of the normal sepsis 3 population that would meet these criteria. They are very young, 100% on vasopressor, ventilated, 90% are on renal replacement therapy, a SOFA of 17, just to get a feeling how sick these are. And this is uncontrolled data, just every patient is his own control, and there are always 2 hours between these measurements. So you can see that the intervention that lasts 2 hours significantly reduces the amount of vasopressors that are used, and you can also see more surprising to us at this time, the requirement for fluids went down, and the stroke volume variance, so the preload, within a 2-hour window, so it really seemed that the intervention have made this, went down from 15 to, let's say, 7%. So the question was, does it also interfere with the permeability so that our volume strictly stays intravascular? The structure one has to look at in this context nowadays is obviously the glycocalyx, you know, kind of a sugar structure on top of the endothelium that's highly regulated and important for the integrity. And during systemic inflammation, enzymes there that degrade most of these sugar structures, like one of them being heparan sulfate, and we have the heparanases that cleave these structures. So it's like a scissor that cleaves the glycocalyx into small pieces. And if you look into our cohort, we really see that heparanase 1, the enzyme that cleaves into small pieces, is extremely upregulated, and heparanase 2, the counterpart, is downregulated. So we have an acquired deficiency in heparanase 2. And if you look into the patients, you see here, this is essentially the stuff from our ICU. They are healthy, most of them, and they have a normal ratio, so more protective heparanase 2 than heparanase 1. And the septic shock patients from the study have a dramatically disbalanced system, and performing one single plasma exchange totally rebalanced this system. It's no wonder, because we exchanged into plasma, and the plasma was from healthy young donors containing the entire repertoire. Does it really matter in terms of the leakage? So there's one technique how you can visualize this, and it's just a staining of endothelial cells. Might look a little bit theoretical for a bedside physician, but I want to make a point here. You see these cells are connected with junctions. That's the barrier between the vasculature. And if you drop blood of these patients on these cells, you can see 2 things. The cells contract, and the junctions disassemble, and this leads to the formation of these gaps. And that's actually not goofy science. That's the correlate, the cellular correlate of the patient in severe capillary leakage that you see. If you perform a plasma exchange with this patient and you take his blood afterwards and you re-challenge the cells with 2 hours later drawn blood, you completely improve this phenotype. So at least something is not in this blood anymore that induces this phenotype. You can also nicely quantify this by measuring the resistance over the cells, and then you see the effect in all the patients, but that's published data. So remember the pictures I showed you before, this was not for no reason, this was because we also did this obviously before and after a plasma exchange. And that's a patient in septic shock from this trial, and you can see this one is not so important because it's not a capillary, it's a large structure, but if you look at the smaller ones, you see there are some regions with movement, but in most regions the flow is extremely slow, the flow is extremely slow, and we performed the plasma exchange, repeated the test with the very same patient, and this is really subjective data. We were not able to quantify this at that time. Now there are machines that can actually give you numbers and quantify the amount of erythrocytes per time going through differently sized vessels. So it's really interesting to repeat these experiments to get a number out of this. It's just to make my point actually to you. And why is that so? I think, remember what I spoke about the coagulopathy, it's because we're interfering also with this system. Just an example, whatever you measure in the blood that's out of the range, so whatever it's elevated, it's essentially a regression to the mean of the donors of the plasma. So fibrinogen as an acute phase protein is up, no wonder, and you bring it down to normal range. And those things who are down, I think that's the really interesting point, like, for example, protein C. You increase it because it's contained in healthy plasma. So I want to highlight this von Willebrand factor system one last time in this context. Remember the sticky protein that is so highly abundant. After plasma exchange, you remove it, you almost bring it back to normal. And the enzyme that's responsible to chop it into small pieces that was reduced, some of them dramatically and below 10%, you bring it back to a range close to normal, not to normal in our setting here. So what about control data? That's all uncontrolled data before and after. It's scientifically not very valid. I thought, impressive data, but there is no control group. So there was a paper 2 years ago from Keith et al., where they did a propensity score matching. So they also use plasma exchange in their routine practice in severely sick patients, essentially 2 pressors and evidence of multi-organ failure. And they checked for mortality and matched twins for age, gender, and some acute scoring in terms of their acute illness, so for Apache, vasopressor inotropic score. And they improved survival by around 20% significantly in this, not a randomized controlled trial, but a propensity score matching. And while we were still waiting on the money to perform our multi-center trial that we wanted to do, but we had the ethical approval and everything was there, we were encouraged by this propensity score matching, and we said, let's just do it, let's just start without any money. We do it kind of like by ourselves in this group between Bonn, Hanover, and Zurich, and we choose a different endpoint, so hemodynamics after 6 hours, to have like a smaller number of patients that we required, essentially powered for 40 patients. And we had to screen quite a lot, 558 patients to have 40 in the study later. Same as before, it's only 10% of the patients I'm talking about, I guess, here. And these are the results. This is now a control group, and this is really important data, I think, because you see in the red bars the standard of care, all the treatment that you do all the time, antibiotics, volume responsive assessments. You see that the median and norepinephrine dose goes down a little bit after 6 hours because we're doing a good job. Although it was not significant, it goes into the direction that we do something. But the group that had an additional plasma exchange in the middle brought it down to a median of reduction of by half by this procedure in the controlled setting. We looked for secondary endpoints which didn't meet any significance due to 20 versus 20, obviously. And I skip this part. So the last question I wanted to address is, can we improve our multi-center trial by identifying those patients who really benefited from this treatment and exclude those who do not benefit? I tried to do this by having only early septic shock and very severe septic shock, but it's extremely rude, and we're talking about individualizing therapy, but it's a tough one. So we measured everything that one can imagine, I guess, to identify a subset of patients that was the responding subset. And the only thing that really was statistically extremely robust was the initial lactate when we randomized them. And this is a model, so we look at 3 lactates at initiation, and we then look what happens with noradrenaline. And the blue lines are the control treated lines. So if your norepinephrine, if your lactate was above 2, septic shock, it needed to be above 2, the standard group also improved their norepinephrine. So that's probably not the group that will benefit from a plasma exchange if if hemodynamic stabilization would be the endpoint that we're looking at. But if you look at the other two groups with a lactate of 4 or 7, you see that the standard group does not improve. And here the standard group does even worsen their norepinephrine dose. Whereas if you perform plasma exchange in those, you see a more dramatic effect, making the point that lactate might be something that would help us. So where do we head from here? There are actually 2 randomized controlled trials almost at the verge of launching. One is our trial that will happen in Germany, Austria, and Switzerland, the Exchange 2 trial. And we will include septic shock patients at an early stage with a high dose of vasopressin, and we will stratify them for lactate. It's one single intervention. And the horrible endpoint that I had to choose, because otherwise they would not have given me the money, is mortality. We had just heard that's probably not a good one, but otherwise I could not have done this trial, to be honest. And 23 centers will participate: Germany, Switzerland, Austria. It's funded by the German Research Foundation, and in Switzerland, supported by Octapharm. And we will start, I hope, next month, including the first patient. And there's the group in Canada, remember the group that did the meta-analysis 10 years ago, Emily Rimmer, and I'm in close contact with them. They had the very same idea that this could be a good thing to do, and they planned, unfortunately, in parallel, a trial that's not so close to ours that we can put our data together, but we try to join forces here. They will include a little bit less sick patients, so sepsis plus vasopressor, but no dose requirement, and 1 organ failure. And they will perform 5 plasma exchanges, and it's designed as a feasibility trial. That means, so the funding structure is a little bit different in Canada. They have money for 17 patients, but if the trial then looks feasible, they can continue this trial by getting more money from their resources. I think it's an interesting design, and they have a very nice infrastructure, so I'm very positive that they will generate good data. 7 centers in Canada. So let me summarize this. I'm already a little bit over time. I spoke about the theory behind this. Why should it be a good thing? And it's mostly, from my point of view, because we replace stuff that's consumed by the disease. You've seen that this can lead or might lead to hemodynamic stabilization in some patients. We talked about coagulation, permeability, and microcirculation, 3 things that are, I think, or I believe, that are influenced by this technique. You've seen the pilot RCT from our own group and the enrichment strategy with lactate. And last but not least, you've heard about these 2 new larger trials that will hopefully give us some new insights in the next years. Thank you very much for listening.
Thank you very much. Professor David has another obligation. We may have time for 1 question from the audience. You will have to be loud in projecting your voice, though. Any questions from the audience? If not, I have a quick question. We have in many ICUs, we have the capability to do therapeutic plasma exchange. What we may not have access to, are robust tools for, what I would call bedside predictive enrichment, figuring out who will benefit, who will not. You talked a little bit about lactate to stratify patients who may benefit from plasma exchange. What other, if you're at the bedside, you're a clinician, what are some other biomarkers, clinically available biomarkers or physiologic features that you would use to help identify patients who could benefit outside the context of a trial?
So just for, if I would take it as a therapeutic intervention and not having a trial, so it's usually the typical patient. We did this over years in an uncontrolled fashion. It was a young person who was super sick, very early, pneumococcal septic shock, 3 small children crying in the waiting area. So, and then you think you have to do something somehow, not really scientifically, but that's also our nature as a physician, I guess. So from my experience, what we did over 10 years at my old institution in Hanover, where this all started, was if the patient was really young with a very good prognosis, but he was extremely sick, like toxic shock context scenarios. But when we were looking at whatever biomarker you can think of, we also did a lot of immunophenotyping with a lot of really clever people that collaborated with us to find a subset of patients, but we couldn't find it in a small number. So for the large trial in which we include 300 patients, we have already predefined a lot of sub-studies with a lot of experts that are not really involved in the trial to help us find out at the end of the day if there are patients who really benefit. I'm sure there are patients who benefit, but I've also seen patients who do not benefit at all. So I've also seen patients, they looked alike, very young, very sick. You did this strategy and it was the very same at the end and they still died. So this is the task, I guess.
One quick question from my side. Do you think one plasma exchange would be enough?
So, you know, traditionally we've done 3 to 5 plasma exchanges, and the reason was presented by the speaker before. A large molecule like IgM, strictly strays intravascular, you can remove 90% with 2 exchanges. Small molecule like IgG, and this is why you use plasma exchange normally, that kind of distributes in your whole body. So you need 3 to 5 exchanges to bring it down below 90% because of the redistribution phenomena. We did 3 at the beginning, and I analyzed it in retrospect. So during the time when we didn't do a trial, we always did 3 exchange. And when I looked at hemodynamic stabilization as one easy-to-access endpoint, you always saw that the first treatment did something, but the second and the third did not do anything at all. So this was our very pragmatic decision to go for one single intervention at the very beginning, improve organ function in the first 12 hours, and have an effect in the long run. That's the hypothesis, and that's might be wrong.
Thank you very much.
Thank you.
Thank you. Ladies and gentlemen, let me welcome the next speaker. It is Professor Pappalardo, and he would talk about what is hemoadsorption. Thank you.
So good morning, everyone, and thanks for this kind invitation in the beautiful Brussels this morning. So before I start, I have to tell you about a couple of disclosures which I think are key in this presentation. So first of all, I'm not an expert. So I do use a lot of cytosorb therapy, but I'm not an expert about extracorporeal removal technologies in the field of renal failure, for instance. But I learned a lot by preparing this presentation. The second is about what is the clinical sense and the trajectory of this topic from a different perspective. Because listening to the kind of patients population description that I have heard, if you work in a cardiac setting, you will understand that you definitely have a different viewpoint. So the doses of noradrenaline which are reported in these trials are forbidden in a cardiac patient. So we would never have a patient with such noradrenaline dosage. So it goes back to the issue of timing, that it's key in this regard. The second point that I just want to mention you about the clinical perspective is that renal replacement therapy in the cardiac setting is a failure. It's not an option for treatment, because the acute kidney injury is a marker of poor cardiac output. So we want to have all our patients passing urine, and we are not happy when we start renal replacement therapies. And that goes to the technicalities which are behind eventually hemoadsorption and generally speaking, blood purification technologies. So the field is, when you come to this point, that you have to understand that there are opportunities for blood purification technologies, and amongst them, you don't have to compare apples to pears. But what is the first concept that I learned? When I started to use the cytosorb, I learned that it should not be called a filter, which is absolutely common. When all the colleagues will start this treatment, they will call it a filter. So maybe this is easier to make you clear what is the difference between filtration, so as you do with the coffee, and adsorption with tap water to be drinkable. So in blood purification, we have different technologies. So it's not just hemoadsorption, and you have convection therapies, combination of therapies. So adsorption is available, but in a different perspective in other systems, or you can have different therapies such as plasma exchange as previously described. So the cytosorb is the one who I am more familiar with. And again, if we try to go into very simplistic models of how to describe the difference between filtration and adsorption, filtration requires a membrane, definitely. Adsorption requires a structure or infrastructure which is able to capture molecules. And there are, of course, different structures. So hemoadsorption can be performed with different hemoadsorbers. They are not all the same. So the filter, which we described earlier, is requiring a membrane. And you have two mechanisms which drive the clearance of substances, which is diffusion and convection, which are mostly related to an equilibrium of pressure and concentration gradients. Whereas adsorption is a physicochemical binding. So there is a molecule which sticks to infrastructure. And the performance of these technologies are driven by multiple factors. So first of all, their molecular weight, hydrophobicity, and of course the electrostatic properties, because a molecule can stick to a different sorbent according to these chemical properties. So if it's able to bind negatively charged or positively charged or neutral charged. If you look at this perspective from the of opportunities to remove molecules, I think it's very important that we go into the clinical viewpoint, which is about which kind of molecules are we removing. And we should know what is the spectrum of molecular weight of molecules which are in the blood. And so how much of these molecules are removed according to their molecular weight. Because of course, you can remove a lot of molecules. We have come to the issue, of course, of potentially removing molecules which can be beneficial to the patient, but this is very much dependent on their molecular size. And I do believe that many molecules which are key for our health do range in the larger size, such as albumin and immunoglobulins. So again, adsorption is when you have this interaction, which is a physical interaction. There are other technologies besides cytosorb which are able to produce an hemoadsorption effect. But this is completely different according to the surface of the sorbent. Because one of the most important factors which is driving the efficacy or the efficiency, I would say, the efficiency of the technology is the size of the surface which is exposed to blood. So this is ultimately, in our perspective, translated into a cartridge, which is not a filter, but it's got to be a cartridge. And if you look at the properties in terms of capacity of removing molecules, this can be unselective, so it's a range of molecular weights and physical characteristics of molecules in blood which are removed. You can have selective hemoadsorption, so as mentioned previously by Gabriella, and this can be naturals or synthetic materials. So the interaction between the molecules and the sorbent can be hydrophobic interaction, electrostatic interaction, hydrogen bonding, and van der Waals forces. But what is most important, I think that it's about the surface area of the cartridge, its biocompatibility, so how the cells and the plasma proteins interact in keeping the cartridge active, well-functioning or not. The molecular weight, as mentioned, of course, the concentration in the blood. So removal is dependent on blood plasma concentration. We can discuss whether blood flow is a major driver of the efficiency of the system. So how much blood is passing through the cartridge? Is it driving the efficiency of the system? And of course, it's always about how much of these molecules is at the same time being produced by the patient himself. So if we look at, let's say, rhabdomyolysis, for instance, is your limb still ischemic when you are starting this treatment or not? Are you suffering from reperfusion injury or not? Did you do fasciotomy or not? Because, of course, we cannot forget that first, this is an adjunct. So we have to look at how we are able to treat the primary disorder and how the primary disorder is behaving biologically in this regard into the patient, and so we can look how the system can effectively work. The other point about the efficiency of the system is that it's not like a colander. So you cook the pasta and you water is out and you have your macaroni. It takes time. It's not a matter of 5 seconds. If you look at the concept of drugs removal, It takes time, and the time is different according if you have, for instance, ticagrelor or rivaroxaban. When you use these technologies during CPB, the duration of CPB is definitely one of the major determinants of how the system is efficient, because different molecules have different kinetics through the adsorbent, because the process of adsorption, as here is clearly shown, it's quite a bit complex. I was not aware of such complexity of the interaction of the passage of blood through these pathways which are in the cartridge. And the cartridges are multiple, so as mentioned, I'm biased because I'm using only cytosorbents. I have no experience with these technologies, but this is another example of how the sorbent is, let's say in this case, completely different because it's selective in this regard. And whereas the cytosorb, it's able to remove a wider spectrum of molecules, and the capacity of this removal is driven by the large surface, as mentioned. The molecular weight of substances is up to 60 kilodaltons, and of course it's concentration dependent. I think it's very important when I started from the beginning, then the technicalities which are behind the application of these techniques is very important. So we do not rely on renal failure to start treatment because we do not want to use CRT. So it's important in our perspective that this technology can be used as a standalone, or it's compatible with CPB, ECMO machines, and the anticoagulation procedure, which again, it's very important in the cardiac patient, is not affected by the technology. So the substances which are removed with this technology it's quite broad, let's say biologically speaking, but also clinically speaking. So that turns into a broader adoption of this technology, not just to septic shock. So this technology is able to remove molecules which play a role in determining the pathophysiology and eventually the negative outcomes of septic shock patients. But we do believe very much in sterile inflammation as a significant driver of morbidity and mortality in our patients. We do believe that we have to remove also toxics such as bilirubin, myoglobin, which is a wide application in the field of the cardiac patient. And ultimately, we have this specific issue of removing agents which promote bleeding in the surgical patients, such as ticagrelor, rivaroxaban, and also intoxication. So, for instance, venlafaxine can be removed with cytosorb. Oxiris is another technology, but the surface for hemoadsorption is definitely smaller. There is heparin in this cartridge, which I personally do not like. The Jafron is outside my competence, never used, so I have no experience with that. But it's very important, again, that we look in our clinical perspective of how these technologies can be deployed at bedside and how they can be integrated in our setup at bedside. CRT is an option, but we don't like to use CRT. CPB can be a good platform for using the cytosorb for removal of drugs when you are undergoing emergency cardiac surgery, and this can be done in multiple arrangements without changing the anticoagulation protocol. When you look at this device, so the CPB and ECMO machine, the flow which can be produced across the cartridge is in between 100 and 700 milliliters per minute, which means that generally speaking, it's let's say between 200 and 300 according to the pump flow, and anticoagulation is usual. So what is removed, as mentioned, endotoxin or exotoxin, toxic substances, drugs, which is very important, mediators of inflammation and immunocomplexes. And therefore, the field of application is by far broader than septic shock. So it's septic shock, systemic inflammatory reaction syndrome, which is also driven by sterile mechanisms. You can treat patients who have acute decompensation or acute liver failure, intoxication, you can remove drugs, and of course you can have a wide application of this technology in ECMO therapy, either VV or VA, And if you are doing DCD donation when you are performing normothermic reperfusion of the splanchnic organs with ECMO, or if you are doing machine perfusion ex situ with also this technology. So the rationale behind, of course, it's as mentioned that there are multiple mechanisms that can drive hyperinflammation. It's not just infection, but also the therapy that we provide. And this sterile inflammation is very important from my perspective to drive the potential cytokine storm in cardiac surgery. And the target is to mitigate this phenomenon, so to alleviate and to have some, let's say, proximity endpoints. So as discussed, we cannot consider these adjuncts driving mortality at 28 days in our patients. So we have to look at these opportunities as a tool to stabilize the patient and to mitigate, to mitigate some side effects of administering tons of noradrenaline, which is driving to multi-organ dysfunction for sure. And having shock reversal or hemodynamic stabilization as a proximity endpoint, which is, I would say, more clinically sound in terms of pathophysiology, because we cannot expect that the patient is going to recover just because we apply a hemoadsorption technology. This can be measured at bedside by clinical labs, so you can assay your values of your targets, which can be, of course, cytokines, but we usually assay bilirubin if you're using for shock lever. We use myoglobin if we have rhabdomyolysis. But of course, it's very important that you use the metrics of noradrenaline and hemodynamic stabilization, and also reperfusion via lactates, because this is a very clinical, a very easy clinical marker of how the patient is stable. There is no evidence, definitely. We know that this is a very large field of discussion about whether we should use this, but there are a couple of messages which are entering into the guidelines, as mentioned. If you have a bleeding patient or a patient who is undergoing emergency surgery who has antiplatelets such as ticagrelor or anticoagulants or board, it is recommended by the European Society of Anesthesiology that you can consider these therapies to facilitate the surgical procedure and to reduce bleeding complication. But don't forget, it's an adjunctive therapy, so don't ask for impossible outcomes in your clinical practice. Thanks for your attention.
Thank you very much. We're going to have a brief panel discussion here in a few moments, but next I'd like to welcome Professor Can Ince, who's going to talk about how these techniques can potentially help to protect the endothelium.
Thank you very much. Well, thank you very much for going out in the rain and coming here to listen to this lecture. As you noticed, yesterday I completely lost my voice, so I hope I will be able to make it to the last slide without going into silence, which might not be a good thing. So I'm going to be talking to you about a more important target organ of extracorporeal circulation and septic shock and states of inflammation, and that is the endothelium. I have declared interests. Most importantly, I'm involved in a company called Active Medical, which is exposing at this center just outside here regarding microcirculation. But the most important thing is I'm a physiologist. I'm not a clinical doctor. So my role here is to shake the cage, to maybe make you think in a different way about things which you're doing maybe automatically in routine clinical practice. So having said that, I would like to take you to this colorful gentleman who is Elias Mechnikov, a Ukrainian immunologist who, not far from Palermo, by the way, on a summer holiday, discovered phagocytosis. He was considered the father of immunology. And he already understood that the target of inflammatory states were the vessels, that's where the lesions occurred, and that was the target of shock. So, of course, now we know that actually what he called the vessels are now lined by endothelial cells, and endothelial cells are a key interface in between the circulation and the parenchymal cells responsible for organ function. They do the angiogenesis, the hemostasis, the blood pressure regulation, the transport function, the inflammation, and a lot more. And inside the endothelial cells, there are all sorts of mechanisms which translate what's going on in the circulation to what goes on in the tissue cells. So if you want to understand what goes wrong, this is the target cell that you have to be focusing on. And in all sorts of conditions, it will start to deteriorate. There is no, it's okay here or it's not bad. At the moment you put 100 mLs of fluid into a patient, the endothelial cells are unhappy. Because one of the main roles of the endothelial cells is to feel viscosity, is to feel shear stress. And that's the interaction of flow, hemodynamics, and vasotone autoregulation. But here you can see there are many such papers which have been produced. A normal homeostasis, we have the glycocalyx, which is a gel-like substance. And in that, there are all sorts of different molecules being expressed, much smaller in height than the thickness of the gel. So the adhesion molecules are like about 100 times smaller than the gel. So if the gel is there, the leukocytes don't see the leukocytes don't see the adhesion molecules. But as soon as the glycocalyx gets shed, like an oxidative stress, then you get rolling and sticking and all the bad things that we know happens in states of inflammation. So the endothelial cell is really a very interesting cell, and we should consider it as a target for different therapeutic interventions. And this was a paper we wrote together with Professor Vincent and Peter Pickers recently, looking at all the different phenotypes of the endothelial cells and what possible interventions could help to protect the endothelial cells or to actually cure them. But we must take, certainly from a physiological point of view, of course, which is a more holistic approach to what we're talking about, one step back. And Hippocrates already said it, make a habit of two things to help. But let's first take a step back and not do harm. Let's start with that. And there's certainly a lot of things that happen in perioperative medicine and critical care which cause harm. Necessarily so, but one must be aware that every good side has a bad side. So if we look at fluids in themselves, we found out that indeed fluids cause glycocalyx degradation. Functionally, that basically means you are making the autoregulatory function less. One of the main reasons why the kidneys don't like fluids that much is this. However, glycocalyx in itself does not alter the vascular barrier. These are a number of studies that we did. If it happens immediately, if it happens for a longer period of time, then it does. So here we see that also in a clinical study, this is a study done by Nature Pure and colleagues, that the amount of fluids that you are given correlate to the amount of peripheral circulars heparin sulfate. So you can measure circulating shedding products of the glycocalyx, such as syndicant-1, heparin sulfate, and this at the moment is the golden standard. But also other things happen. During CRT, for example, not only do you see an upregulation of the glycocalyx shedding products, but also the adhesion molecules between the endothelial cells. And these are the true anchors and responsible for vascular barrier degradation and causing albumin leakage into the tissue cells. So these are VE cadherin, for example, is one, the main one, and you can measure this in plasma in a soluble form as a biomarker too, a much more precise biomarker for CRT. But also all the extracorporeal organ support systems that are there inducing shear stress changes. There's a big discussion in extracorporeal organ support, especially among the perfusionists, whether pulsatile or non-pulsatile pumps should be used, and the shear stress that pumps certainly have a negative effect on the endothelial cells. And here you can actually see it in cell cultures that that's the case, that these are in endothelial cells having anything. And if you look at the different types of left ventricular assist devices, one with pulsatile and one without pulsatile, there's also evidence to suggest that pulsatile, this is the HeartMate 3, causes a lot more problem with the autoregulation of the endothelial cells. So this is the reactive hyperemia index, which is a great and simple test. To see it, you basically give a cuff, and then with laser Doppler or some other measurement of peripheral circulation, you see if it goes up and then goes down again. If it goes up, it means that the cells, the vessels have dilated, endothelial cells, and once the oxygen comes back again, it regulates it back. That's the hyperemic response, a great clinical test which you can use. So let's now get back at the other side of the story, that once all the bad things have happened, what do you do? If we look at sepsis from a physiological point of view, everything that you can imagine happens at the same time. And every minute, the nature, the phenotype of the disease changes. Not only in terms of the expression of all of the different types of cytokines, but also the response of the body to the presence of those cytokines, causing, first of all, a positive effect, but on the long term, a negative effect. So because you don't know this, the only important parameter in critical care medicine is time on the x-axis. And everything is changing in time. But on top of all of this, every time an intervention is made, you give the steroids, the blood transfusion, the fluids, it changes the nature of the disease and the nature of the hit and the pathophysiology. As you start taking over from a therapeutic point of view, normally available physiological mechanisms there, and all of a sudden, lots of catecholamines, lots of fluids, and then, of course, it becomes an uncontrolled situation resulting in organ damage and organ failure, ultimately. So if we now pick out of all of those things, the cytokines, because the cytokines themselves are positive and negative, such as everything in medicine, oxygen, positive, negative, etc. So if we look at TNF, we definitely know that TNF levels increasing have a bad effect on the kidney. And the kidney is important because it really is the target organ and the real sufferer in all of these states. And if we look at the different cytokines, this is one study looking at the effect of cytokines in coronavirus disease, we see that the IL-6 of all of the cytokines is really the one which is the most sensitive associated with adverse outcome. So if we look at manipulating IL-6, we see that manipulating IL-6 is actually very, very good in saving the vascular barrier, as the barriers molecules here, the V adherents, for example, here, become much less if you block IL-6 than if you don't. And looking at the literature across there, you see more and more the idea coming that IL-6 really is the link between vascular pathologies and vascular disassembly. Here you see the VE adherents resulting in leakage, edema, and all of the bad things that happen. And here again, we see that there are certain other, like the C5a receptor, the complement activation too is a key step in all of this. But the ultimate story, of course, is that you cannot get oxygen transport to the tissue. All of these cytokines are causing upregulation of proteinolysis, lipid peroxidation, and everything is going bad. So, what do we do? Do we do another multicentral trial in the New England Journal of Medicine, looking at some unpronounceable molecule that's supposed to solve sepsis? Haven't we done that now for the last 30 years? Nothing has come out. Zero. I would argue that there's not one multicentral trial that has been conducted in critical care medicine which has shown the benefit for patients. Not one. So it's time to leave that, and it's time to look at the physiology. And there certainly is no silver bullet. Maybe for very specific diseases like a clogged artery or something, but not for something as complex as sepsis. And we shouldn't go on a wild goose chase trying to find yet another molecule, expensive, even more complicated, nobody can pronounce. It's not going to happen. Insanity is doing the same thing over and over again and expecting different results. And that's certainly the case for trials. So let's go back again. What is really pushing, fueling this spiral of organ dysfunction leading to death? Well, it is all in the circulation, which is the connecting compartment between all the different organs. And this is a very nice paper, in my view, by Claudio Ronco and Ming Chihuahua and John Kellum and Said, really saying that, we should have more control over the composition of blood if we want to make sure that things don't get out of hand. And one of the steps in all of that is the control of the cytokines. Now, why is that important? If you look at physiology in general, and this can be heart rate variability also, or cytokine storm, physiology needs a level of the different parameters within which it can either give too much or too little. That is regulation. If you are hitting the ceiling, you don't give normal physiology the room anymore to use its properties to alter any type of phenotype that you require. That's the situation with heart rate variability. If you don't have variability, you have a problem. The same as with cytokines. If we have a storm of cytokines and everything is maximum, you do not give the immune system the chance to correct that or to alter it. That's why the idea, which I find very appealing, is maybe not to find out TNF or interferon or any such thing, but just to chill the whole storm and make it a benign rainstorm maybe in which the cells have time to recuperate. And that's the basic philosophy behind hemoabsorption, and what we have done the most research on is the cytosorb. So if you now actually look at what cytosorb does, it takes out a lot of the cytokines, and you can see that if you do that, indeed, endothelial cells especially, seen in this study by Sascha David, these are the pre-cytokine removal. You see all of these adverse, no longer the junctions between the endothelial cells, but if you take it away, you see that cells look a lot happier. So looking again at the complicated scenario in the microcirculation, we can also say, just as we look at getting rid of all the cytokines, we can look also at the target organs as well. You know, this microcirculation is a combination of many, many factors which finally make it it can be red blood cells, it can be endothelial cells, etc. The bottom line is the microcirculation has to transport oxygen to the cells, to the tissue cells. So we can look at the microcirculation. So we can do that underneath the tongue, and in great detail we can look at what is going on in the microcirculation during states of sepsis and particular types of therapy. So here we see, for example, I'm going to start with the myoglobin. It's an interesting compound. Myoglobin is really a very, very dangerous, as you well know, and rhabdomyolysis, I'm from Turkey, and in Turkey we had the earthquake recently in which many people died. Rhabdomyolysis was one of the main causes in the ischemia reperfusion in crush victims, which caused death. And here we can see very, very clearly that the redox state of the myoglobin is responsible for apoptosis and death of endothelial cells. So we did a study, a case study, using cytosorb on rhabdomyolyzed victim. And this was done by Olcay Dilken in our unit. And it was a very interesting thing because it was how probably it works in practice and how important it is to really know what you expect from a particular technique. So we had a crush victim, an accident with a tractor. Both legs were lost, and patient had increasing levels of myoglobin. Now, around this, the EMEC filter was put in its place, and after a while, it was seen that it had no effect on myoglobin. However, we looked at the microcirculation, and it was relatively normal then. As myoglobin levels was going higher and higher, the attending clinician, Hilde de Geus, phoned us up and he says, well, why don't we try another filter, hemoabsorber, excuse me. But by that time, really the damage had been done. And that's what the microcirculation looked like below. It had come to a complete halt. If you then put in the cytosorb, you see it was indeed very, very effective in reducing the myoglobin levels, but too late. So the question is, if the myoglobin had been put in earlier, it would have been much more effective. So this begs the question, is that this might be a good way to look at it. So we did a case study. And we thought, well, if we just look at plugged vessels in the microcirculation as an indication that endothelial cells are not working well, as in this patient before, we added the cytosorb, look at the lactate levels of this patient, vasopressor score very high, a very, very high SOFA score, and after 48 hours, the lactates were down, the vasopressor score was down, and if you look carefully, you can see that all of the vessels are being perfused. And Abele Donati in Ancona in Italy had found the same thing. You see here the reduction in IL-6, Very, very messy statistics here, but if you look at the improvement in the microcirculation, very, very tight signal there showing that the improvement of the microcirculation was associated with the use of cytosorbent. So here we are now conducting, as we speak, a randomized controlled trial based on looking at the microcirculation as an indication for inclusion of CytoSorb. This is our wonderful team working in Erasmus Medical Center and also Haga Hospital, big teaching hospital in The Hague. And here already we can see some very, very preliminary results. This is one without a CytoSorb. You can see here very clearly all the plugged vessels. This is not good. We know from many studies that if you see this, these patients have a very bad prognosis with an outcome of around 50%. And this is one of the first ones that we did. You see the resolution of the plugged vessels resulting in a good perfusion of the microcirculation. Thank you for your attention.
At this point, I'd like to invite our previous two panelists up here to the stage, and we'll do a brief panel discussion. If you could just put your hand up if you have a question, and we'll get a microphone to you. And maybe I'll start with a quick question for Professor Ince. Professor Ince, tell me, if you have a room full of clinicians here, presumably many clinicians, if you could tell everyone one thing that you would really like them to know as clinicians about the endothelium and how to protect it in our day-to-day practice, what would you want everybody to know?
Wow, what a question. I would say beware of using lots of crystalloid fluid resuscitation. I think that's a really bad thing. Consider colloids, despite all the stuff we have heard over the last 10 years. And that's from the hemodynamic point of view, if I may say so. And from the inflammatory point of view, I definitely believe that hemoadsorption and bringing down the craziness in the cytokines is the way forward, as opposed to trying yet another drug. And if you have nothing, there's always dexamethasone. So I was asked this question in two sessions before on endothelial targets. And well, what would you say? Well, I'm not a clinician, but if I was a potential patient, I would like 1 milligram per kilo dexamethasone and a gram of vitamin C before I enter the ICU, to make sure that any craziness that happens after that, I'm well protected against. That's the panel discussion.
Any other questions? Then I might have one. What our speakers suggest is the perfect time for the blood purification start. It should be before the treatment with renal replacement therapy is indicated, I guess. It should be before the sepsis is going the ways we are not able to control, but when is the perfect time for this? Do we have an answer for this?
Of course, it depends on the clinical picture. Underlying in septic shock, of course, an early approach is suggested from the last evidences, because in this way we are able to prevent organ damage associated to cytokine storm. Of course, we have to select the right patients, and we are discussing today a lot about it, about an enrichment strategy, lactate, vasopressor load, are all criteria to evaluate the right patient, but in the right time, that is not too late.
So I think it's important that when we come to the issue of timing, we are aware that, of course, it's not to be early, it's not to be late, but to be timely. Timely, it's quite difficult to capture in critical care medicine. And I think we should play the risk of over-treating some patients as long as our treatments are not harming the patient, so they are safe. But in this regard, we might capture and benefit a larger proportion of individuals. I don't support the early treatment. Early is not correct. I would always recommend a timely treatment. And timely treatment starts from identification of the clinical setting in terms of diagnosis and clinical status. That's why I think we should work a little bit more on having some markers, which are not necessarily biomarkers, but clinical markers, which can advise us on a timely initiation of therapies.
I think this is a very important question. And looking at it from a practical point of view, we're a university clinic, so a lot of the septic patients that we get do not develop sepsis in our unit, but come from outside. So we have no idea when the sepsis has started. We have no idea what they have received, and they usually are full-blown sepsis. That's a large portion are referral septic patients. The second thing is what's very, very difficult about sepsis is trying to find out what is time is T0. When did the septic result actually begin? Was it a cough on the farm? Was it the surgeon who did something stupid? Was it an infection? Was it COVID? So we don't really know. Now, I have a declared interest. I think what you said is absolutely true. Biomarkers are also not an option because you don't know when to measure the biomarker. Another practical aspect is that until recently, and the company now has got a perfusion system, but until recently we needed an extracorporeal organ support system to attach the hemoadsorption. So that too was an important caveat, which really resulted in the uncertainty of knowing when to do. Our idea is a non-invasive imaging technique like what we use to identify endothelial cell plugging, which we know has got a bad prognosis. We know it's associated with cytokine release, might be a way of having a way to differentiate between patients who would have.
Thank you very much.
On top of that, I think that this is, again, to be connected to the patient's characteristics. So, for example, what I call the tolerability of the infection. So a patient who, for instance, who has heart disease has different tolerability of an infection as compared to a healthy individual. So the hemodynamic response will be completely different, and therefore the impact that infection A is going to make in that kind of patient is completely different from the same infection in a different patient. So again, it's not just the biology of the in this regard of infection, but also the clinical background on which it is going to take place.
I have another one, if there is no other questions. I have another question in terms of COVID and cytosorb. There was, as for me, it's a clear indication or the best model of disease with the cytokine storm, which hemoadsorption should work. Although we have conflicting evidence from randomized control trials in Germany, at least, with the negative results in terms of mortality when the cytosorb was placed on the ECMO machine for COVID patient, which might be too late, as we know. There was a study at our hospital where we put the cytosorb on the renal replacement therapy, which might be a proper timing, I guess, or at least not too early, which we were not able to show any better results in terms of catecholamine reduction. Do you have any comments on this?
Yeah, I think that the German study about COVID and VV ECMO has major limitations, and I think it's not applicable to clinical practice. First of all, I always remind that the results in terms of the control group were so dismal that they do not have any sound applicability in our practice. So if a single intervention is making any difference in a patient who's been treated with VV ECMO, you cannot have a control arm who's having a survival rate of 18%. So this is something out of the, I mean, it's not sound and it's not the benchmark we have currently with these patients and therapies. Again, I want to remind you that we usually have this approach to trials where T0 is T0 for everything. So it's T0 for starting the ECMO and starting the cytosorb, for instance. Whereas we have to understand that the dynamics of this interplay between the disease, the therapy, are more complex. So you might have a patient who can just benefit from VV ECMO at the beginning. Don't forget the ECMO is able to put your temperature down. So you cool. If you are febrile, just febrile without organ dysfunction, you can just be stabilized by a simple ECMO run. But eventually, after 3 days, you can have a super infection. So that is the time when you might need the intervention. And when designing this trial, I'm very reluctant to have a T0 for everything. It's a more complex story in clinical practice.
May I add that in this trial there is also a bias selection, very low level of IL-6 in the population, that it is not so good. So the heterogeneity of the population had an impact on the result in this case. Of course, a survival of 80% in the comparison is difficult to show a further improvement, as we have said in our talk. So we have to rethink to how to design our study. This is the most important message, I think, today for this topic and this field.
Thank you very much.
Some studies on the COVID patients. And the important thing here, and I completely agree with my previous speakers, is the enormous heterogeneity in the COVID patients. Yeah. So you have an enormous bias if VV ECMO is indicated for a patient, and I would respectfully suggest that's too late, actually. So that brings the question of when can you then do something like cytokine removal, when you can consider that. We also had the problem that we weren't quite sure what was going on with kidney and acute kidney injury, at least in the first phases. Our radar was on the lungs and not really on the kidney. So when do you do that? So the T0 issue is key. And one person's T0 is someone else's T0. So I would get back that you need some form of a easy way of identifying the impact of cytokines on the vessels, because that's what that clinical problem is what you're going to solve.
Thank you very much.
So if you look at the data regarding COVID and VV ECMO from the United States, which were gathered in the CTC registry, was about the use of cytosorb in VV ECMO. I always remind that when we look at this data, I like to capture the whole picture which was around these patients in those centers. So those centers have published the concept of cannulate, extubate, ambulate, use RVAD, use bivalirudin, and use cytosorb, which is not a single intervention. So it's an adjunct in order to obtain this, strategy. So, we have data that show that if you use the cytosorb in a VV ECMO patient, you can improve your PF. So that turns into then the strategy can be pursued of extubation during less flow, so you can do a single-stage cannula. So it's a complex interplay of factors, and you need to keep your eyes wide open to the target, which is ultimately the clinical benefit to the patient.
As you see, all of our speakers are very optimistic about the cytosorb and the... yes, please.
I come from Bangkok, Thailand. Thanks a lot for the excellent lecture. We use a lot of hemoperfusion, but we use different from China. And we had a lot of surgical septic shock. Some of the patients, we run the hemoperfusion right after the deadly surgery, and the patient did very well. Because we use it before the ILC coming up. And the question for me is that because some patient has a huge level of IL-6. Should we run until the IL-6 coming down to like 100, or because one patient I ran it every 8 hours. She walked back home. Everything went very well. The lung was clear, and we stopped noise. She pee very well, but a lot of people say that we lunch too much. How's your opinion?
Okay. I think that the concept is the cutting the peak of the cytokine level is the theory of Professor Ronco. I don't know if he's in the room. And to achieve the immunohomeostasis. We haven't the need to go down interleukin, chemokine, but just to achieve a new homeostasis. To achieve this result is important to have a continuous treatment for a long time. So continuous hemoperfusion or more session, as in this case for your patients. The experience about blood hemoperfusion in septic shock show that we need at least 3 days to have a stable result, to achieve the homeostasis and maintain the result in the time.
Thank you. Maybe because of the time reasons, one last question. If there is none, I have another one about the dose. And I was wondering, because I guess Dr. Bottari and Professor Pappalardo told us that the dose is very important, and the so in these terms, as the blood flow is very crucial, I guess. So it is that indeed the comprehensive between the apples and beans, something like this. If you compare the cytosorptive effect on the ECMO machine with the blood pumping like 2 to 5 liters, and cytosorp or any other hemoadsorption on the CRT, what do you think about this?
So that's a very good question. I think that we have to come from the, recommendations from the company to our clinical practice and then to our clinical, setting. I think that by using the cytosorb in the ECMO device, it's it doesn't impact your, I would say, the efficiency of the ECMO flow, and you can safely leave the cartridge for 24 hours. So we routinely do 24 hours treatment. That's also true for renal replacement therapy. We keep it for 24 hours. When we go for hemoperfusion, the hemoperfusion system is a little bit more tricky in terms of pump flow, of course, and therefore of anticoagulation needs, because of course you can imagine that the kind of patients we are treating with isolated hemoperfusion is different from those who are on ECMO or CRT, and therefore the anticoagulation strategy is a little bit more complex, and so the durability of the treatment sometimes is lower. I do not have any specific answer to, as we are looking for different molecules, and different molecules have different kinetics. Therefore, it very much depends on how the system is, working in terms of flow.
I think that the doses should be related to the mechanism of action of the technique, in the sense that if you use hemoabsorption in combination with the CRT, but your aim is to use the hemoabsorption to remove inflammatory mediator, the CRT in this case is a sort of platform, is only support, and you have to target the doses in the hemoabsorption. That is on the basis of clinical experience and published studies based on the number of the cartridge, because it's very important to manage the peak of the mediator, to change the cartridge if you have to fight a situation of a cytokine storm. So a change of the cartridge in the same days, every 12 hours, 8 hours, could be suggested to fight with the cytokine storm. And the other point is the duration of the therapy. This is for the absorption, of course. If we talk about therapeutic plasma change, is another things, because it's very important, as Sascha David said, to have at least a free session, but you have to repeat the session after, during the week, to maintain the result. Otherwise, von Willebrand came from the tissue to the blood compartment, and you lose your effect. So the doses should be targeted on the basis of the mechanism of the technique.
Thank you very much. Once again, thank you very much for the vivid discussion. And we have to move on to our next speakers.
Everybody, please welcome Professor Nierhaus, who's going to be talking about emerging indications for blood purification technologies.
Yeah, thank you, and good morning. We're running a bit late, so fortunately my talk is rather short, so maybe we can make up some minutes. Here my conflicts of interest. Now we shift the focus a little bit from sepsis to other indications of hemoabsorption, I think, to give you an overview of what else can be done with hemoadsorption. And of course, there are many, as you have heard already, many modalities and technologies out there that are more or less complex. I will focus in my talk on the absorption with cytosorbents. And I will also give you some clinical vignettes, some case reports, so that you can get a feeling what we actually do with hemoadsorption apart from treating cytokine storm and sepsis. So let's take rhabdomyolysis to remind you that rhabdomyolysis has many causes, traumatic, mechanical, as you see here on the left side, but also metabolic causes are there for rhabdomyolysis, like drugs, hypokalemia, malignant hypothermia, not really the most common conditions, and therefore my cases will focus on the traumatic and mechanical causes for rhabdomyolysis. Myoglobin, as you've heard, is a very pro-inflammatory and aggressive molecule once it's freed and once it's acting inside the kidney. It's not only because it's plugging the tubules, but it's primarily, of course, its pathological action is due to pro-inflammation that precedes the actual obstruction of the tubule. And that's what you see in a patient with profound rhabdomyolysis after a couple of hours. So this was a young male patient who had experienced extensive trauma to the legs, to thorax, to the abdomen. And he went on our ICU after corrective surgery. However, he had bilateral compartment syndrome. We had to do fasciotomy. And as you see here, he had excessively high myoglobin levels. And this is one of the reasons we treated him not very early, as I must admit, with cytosorb in addition to CRRT. He underwent 4 sessions with 4 cartridges, and what we could show is, the lack of a control, of course, a very steep decrease of myoglobin and CK values. Another case was another young male who suffered from rhabdomyolysis of both upper thighs following excessive exercise and hypothermia. It was a very hot summer at this time in Germany, and this guy was made a very intensive exercise within his duty in the army. And he suffered from bilateral bilateral compartment syndrome. Again, he was fasciotomized too, but the damage had been done. As you see here, he went into anuria oligoanuria, and we started him on CVVH and combined again cytosorb to lower the myoglobin. This was a rather fortunate case because he started passing urine after a couple of hours or days and came to a full recovery. So this is another clinical indication how we would use cytosorb out of sepsis indications. Now, you may say these are all cases. Where are the controls? We looked in our database for a matched control, a young patient with ARDS, propofol infusion syndrome, high myoglobin levels, who was not treated with cytosorb. And you see here what the natural course of the myoglobin levels would be if you do not use adsorption therapy. So rather prolonged exposition towards myoglobin and, of course, renal failure afterwards. So this was our internal control, so to say. Now, another indication, apart from sepsis, again, an anecdotal report is acute liver failure. I show you a male patient, rather young also, who suicidally ingested a lot of paracetamol and alcohol. He went into acute liver failure, as you would expect from this dose, with hepatic encephalopathy and multi-organ dysfunction syndrome. The time course was as follows: massive increase of liver enzymes, decrease of factor V, as you would expect in acute liver failure, high lactate, metabolic acidosis, CVVH-D4, acute renal failure, and then we added high cytosorb to the circuit, as you can see here. And we observed a very interesting course of the liver enzymes and the bilirubin lactate. This patient was actually listed for a high urgency transplant because we weren't sure which way this would go. And of course, after detoxifying and after giving antidote, etc., we still weren't sure if this wouldn't be a case for a high urgency liver transplant. And meanwhile, concurrently, we used cytosorb adsorption therapy, and everything went well. And this patient did not have to be transplanted, maybe due to the intervention, maybe due to chance, I don't know, but this was another incentive for us to look beyond the sepsis indication for using cytosorb. So there's a lot of literature out there. Of course, in severe drug intoxications, you hardly ever have any control groups. So this is more or less case reports and with a certain reporting bias, of course, because reports that end up with mortality will not be published. However, the substances you see here, lamotrigine, digoxin, quetiapine, amlodipine, they can all be very effectively adsorbed by the cartridge because, as you know, it's a very powerful adsorber. It adsorbs unspecifically anything that is up to a certain molecular size around excessively in the blood. Also in cardiology, cardiosurgery, there are emerging indications for cytosorb apart from sepsis. As Federico has mentioned already, rivaroxaban, the new oral anticoagulant drugs, can be effectively removed from the system. And I'll show you one set of data from Germany that has been published recently. There, the colleagues used in high-risk patients who had to underwent high-urgency cardiac operations and were on rivaroxaban or ticagrelor. They could reduce with a very high significance the amount of post-operative bleeding and the drainage volume. So there was much less blood needed in patients who underwent cytosorb pre-therapy for the almost quantitative reduction of these anticoagulants. So that's another, I think, emerging indications for the system. Further, organ transplantation and CAR T-cell therapy, there are a couple of reports and preliminary papers out there that show that primary graft dysfunction in solid organ transplantation and also animal experimental study after lung transplantation and donor procurement, these are also emerging indications for CytoSorb, and I think we will see much more in the near future about preconditioning both organs and donor, as well as pre-transplantation and of course also the reperfusion injury after solid organ transplantation, another indication I think that's upcoming. CAR T-cell therapy is becoming more and more widespread. There's a nice report out there also from Hanover, but I choose this one from France to show you that even though tocilizumab has been used in this patient, the additional use of CytoSorb here, together with renal replacement therapy in a therapeutic refractory cytokine release syndrome in CAR T-cell therapy was obviously very successful and effective, which is not only shown by the course of the interleukins here and the cytokines, but also clinically relevant, I think, by achieving a very rapid restoration of fluid balance and achieving a negative fluid balance within a couple of hours, actually. Very interesting data. So if I conclude this list, severe drug intoxications, cardiology, cardiosurgery, solid organ transplantation, donor procurement, cytokine release syndrome, and as I've shown you with our cases, rhabdomyolysis and acute liver failure, these are, to my knowledge, the current and very promising emergent indications for hemoadsorption. And I think this is a different approach, of course. It's not treating sepsis. It's not, well, you know, interfering with immunology on a very undefined way. But it's, I think, a very targeted approach because in these cases, we know the bad guys. We know what we have to adsorb, and there's no, at least in drug intoxications, there's no ongoing production of the cytokines, for example, like in sepsis. So this is, I think, the pharmacological and pharmacokinetics in these cases are much simpler than in sepsis. So I don't want to leave this session, of course, to give you a very recent information. This again is about sepsis, of the group from Peter Pickers in the Netherlands, who just published, I think it's like 24 hours ago in Critical Care, this landmark paper, and they used healthy volunteers and they injected LPS. Very ambitious model, I think. But they did it, and this is what they could show in a non-septic healthy volunteer group who just received as volunteers lipopolysaccharide as an infusion and a bolus before. And they looked at two groups, LPS challenge with or without CytoSorb attached. And they also 1 week later, fortunately all these volunteers survived, but 1 week later they came back and got a second LPS challenge. And look what they have found. I think it's very, very convincing data, proof of principle actually, even though it's healthy volunteers. But for the first time, it's a proof of principle that CytoSorb does exactly what it expected to do, quantitatively reducing TNF, IL-6, IL-8, IL-10, many other substances. And this is also true in the second challenge. This doesn't reach statistical significance, but you also see the second challenge is much less extended, and there's obviously some tolerance in between. But again, this is a very effective way to remove cytokine storm like substances like IL-6 and TNF. So I think this is a very interesting paper, and it just came out the day before yesterday or yesterday. The authors conclude that CytoSorb therapy could be of clinical benefit in conditions characterized by excessive cytokine release. This is what we always thought and always still think. But then there's now experimental evidence that is very convincing, I think. And yeah, with this, I think I stop and talk a little bit about the road ahead for us, because of course we are looking again at the classical indications for CytoSorb, that is refractory septic shock, both a monocentric study which is currently recruiting in patients with classical bacterial sepsis and high inflammatory load, measured by high IL-6 values, and all we're doing the same multi-center study, randomized control trial, to put more flesh to the bone, as we say in German, to put more evidence to our assumption that CytoSorb is an effective treatment in cytokine storm in sepsis. Thank you very much for your attention.
Thank you very much, Professor Nierhaus, for the very clear introduction. And we will have the panel discussion later, if it's okay for you. And we will move to our next speaker from one northern German city to another. Professor Mitzner will discuss the safety issues of the hemoperfusion. Thank you very much.
Mr. Chairman, ladies and gentlemen, this is about safety of direct hemoperfusion. And well, it's again the majority of data is deriving from the CytoSorb, but we have more direct hemoperfusion devices. As you will know, especially endotoxin absorption is used in Japan and was tested in Europe. It worked in Italy well, it did not so in France, it's studied in the US, and we'll see, I think, data the next upcoming years as to whether this will find a place. And so long I will focus on the CytoSorb data we have on direct hemoperfusion with regard to the very important question of safety. This is lovely Rostock, come and see us, and my disclosures. We were among the first users of the CytoSorb device clinically, and we did preclinical work, especially in studying the removal of drugs, and this is what I will talk about. But first, if it comes to safety, is it a safe device? It may be useful to look at the binding mechanisms, what is it and what can it eat actually? And you might have seen this before. There's one message: if you have molecules larger than albumin, so more than 66,000 Dalton, the probability that the absorber will massively absorb it is low, because they are just too big to enter into the inner structure of the sorbent beads. And there's actually data proving that. This is from colleagues from Switzerland, and they followed in the cardiac surgery setting the coagulation factors of their patients pre and post, and there was no difference, So, and they followed up these patients over the first days post-op, and that was pretty safe there, and seems to make sense, having said that before, because these obviously are large molecules. So it's good. It's not taking coagulant factors. A second way to look at absorption is deriving from an idea that Claudio Ronco gave to the world with the peak concentration hypothesis, that if something comes with a high concentration and is passing over a sorbent, you have a higher chance to remove molecules than if it comes with low concentrations. So I show you an example here as well. IL-6 was mentioned before, is one of the key targets of this sorbent. And in this study, colleagues from Germany studied refractory septic shock with very high IL-6 levels to start with. You see that it's a logarithmic scale, and that was near 100,000, the level to start with. And there was significant removal if they used the sorbent. And they were more on the left side of this scheme, Another study from Germany that had septic shock patients and sepsis patients started on average not with 100,000, but with 500 IL-6 nanogram per mil. And you see there was no difference as compared to the control. What was well, not welcomed result of that trial, but basically is a safety signal, you know, that you cannot bring a concentration really to zero using sorbents. And that's a good signal safety-wise. So they were more on the right side of this scheme. The most important, probably, a way to look at safety of a medical device is look at clinical reports. So what do the colleagues report in their studies, you know? So, and there's plenty of clinical reports from single cases, single series to controlled trials and a registry. And the uniform signal basically is that it was felt to be safe to use in clinically critically ill patients. You see just a collection of trials, and they all reported that they felt it was safe. There is side effects. Probably the one everyone is experiencing is that platelets go down a bit, 5 to 10%, but that typically does not need any clinical intervention, you know, so it goes away, so to say. And you see on the bottom, there's the interim analysis or final analysis, meanwhile, of the CytoSorb registry, published last year in +1, and with 1,400 patients in, and again, there was a very good safety profile published. And Mr. Chairman asked this question: can the product do harm? And we have studies showing that, you know, that the CytoSorb went worse than the control. And it's worth, obviously, to pick the right patients, you know, and there's accumulating knowledge that you cannot save all these patients. Well, yes, and we have indication that, for instance, it makes sense. This is a study where colleagues have, oops, sorry, can you go back just one? See, this is overall this was a good analysis, seeing that using CytoSorb would improve survival, you know, in the septic shock group. But the interesting signal is if they looked at platelets to start with, you know, and they grouped their CytoSorb patients as to whether they had more or less than 100 platelets, that this made a difference in outcome later, you know. So you probably must be aware, if you have low platelets to start with, that you have worse outcome as if they were above 100. And the same signals the other way around for lactate. And lactate higher than 6, you know, even if this, as we all know, you know, typically comes down to normal if you are a survivor, even then this made a difference, your starting lactate, at least in the setting of septic shock. So again, the right choice of the patient's starting point, start early versus late, etc., will give us better results. And we cannot say, is it the disease that is just too bad that we cannot save the patient, or is it a side effect of the treatment? So if we pick the right patients and there's signals how to do that, or we're learning there, again, that could contribute to clinical safety if you want so. Okay. And then we can save some time, because Axel Nierhaus obviously has time enough during this meeting to read the literature, as I did. And you saw this, and again, besides the fact that yes, it is eating cytokines, there seems to be no danger signal with regard to immunological safety, so the tolerance induction is not disturbed by using the sorbent. But now to the core, that's about does it eat drugs? You know, does it take out antibiotics and other valuable drugs if we use it in our critically ill patients? And the answer is yes. What is no surprise, actually. So here is a current study where the colleagues followed vancomycin levels in their patients. You see 7 patients, and if there was no sorbent in, you see the red ones, They followed the levels, and so what we, I think, all would probably find if we would do drug monitoring, that typically we are either in the range or too low, you know, often too low. So we all dose too low. But definitely if the sorbent was in, you know, in blue, you know, they were all way too low, you know, so the adsorbent is eating vancomycin. So what did these colleagues then do? Well, first, yeah, just to add, if you're interested in that, it's not unspecific completely, but you could predict, you know, what drugs or substances would be taken by the sorbent or by filtration or dialysis. If you have a drug with a high free fraction, you know, or with a low volume of distribution, at lowest everything below 2 liters per kilo, then you have a high chance to be removed either by filtration techniques and dialysis or adsorption. And the vancomycin has both, you know, high free fraction and low volume of distribution. So, and what did these colleagues conclude? They said, well, see, this is the levels if we have no sorbent in, and here if we put it in after 10 hours, here you see it go down, the vancomycin levels. And they said, well, then we want to implement a strategy that we just give an extra bolus. Whenever we bring a new sorbent, we will give 500 milligram over 2 hours extra, and we'll be fine then, and that in fact was the case. So that's one way to handle this. Okay. And there's data like that for a number of drugs. This is meropenem, single case, you see 4 days and 4 cytosorb treatments, a couple of hours, and there were 3 grams per day meropenem, and still the levels tend to go down. It was not critically low, you know, but still, again, there's some adsorption, and we can look at the volume of distribution, very low volume, you know, but low free fraction. Still, they conclude, whenever possible, try to follow your drug levels monitoring, or start with higher loading doses or shorter intervals right away, what I think is a clinically valuable hint. In vitro work is suggesting, you know, this is where different drugs you cannot see, but you can see the curves. You know, what I want to show you is what we can learn is if the sorbent is adsorbing, then within the first minutes of use, you know, 15, 13 minutes, maybe the first hour. And we can learn clinically if we put in a new drug, probably it's not a good idea to just at the same moment give the bolus of your drug, but just wait 30 minutes or use a higher concentration as the colleagues did in the vancomycin study. There's a lot of good work was done. You know, this is from Antoine Schneider's group from Switzerland, and they had pig experiments and had tested anti-infectives and how they are removed with the cytosorb, and they grouped them in moderate, mild, and neglectable. And they say yes, fluconazole, linezolid, liposomal ampho-B. And some, yes, you have to consider that. So we have good clinical data, and you can read this in scientific reports, what they found. And the best summary so far I know of is Shire and friends from last year, and they went through all the literature and tested some 50 drugs, different drug types, as you can see here, and again, they grouped them, the knowledge, into removal rates, low, medium, and high, and came up with tables like that. And I just show you that they are consistent. You can read this on your own, obviously, and they say no problem here on the left side, and then intermediate or only in vitro data in the middle, and then clinical evidence for high removal rates on the right side. You know, so, and this is for all these drugs, and here's more of them. I see again the vancomycin in there. And then colleagues from Italy, hinted at something that makes a lot of sense, that we mostly, in most cases, we at least in Rostock, use the sorbent in connection with CVVH. And there's two methods that remove drugs. And we shouldn't forget that. And obviously, it really is especially important if you look at drugs that are taken by both mechanisms. And there again, you'll find the vancomycin in, but others as well. This I think I can skip because, again, Axel Nierhaus, I think, mentioned that drug overdose is a chance. If you can remove drugs, then obviously that might be clinically helpful. And we did, Andreas Köttke from our group had shown in the lab that the sorbent is binding rivaroxaban, and others have done this for... He said, yes, maybe someone wants to make use of that clinically, and lab data of this we have for all the new orals and for ticagrelor as well. And clinically, we saw that trial from Hamburg where they put or put not the sorbent in the cardiopulmonary bypass, and the drainage volume went down and the side effects went down. So brings me to my conclusions, and that is the clinical reports we get mostly say it's safe to use in critically ill patients. It clearly is important to select the right patients, and we are learning our way there, and there's some indicators, lactate, platelets, early start, to help us there. Drug removal is relevant but not for all drugs, and you read the lists, or your way with the high refractions, or you just monitor and dose higher. That could be probably the most practical advice. Interesting therapeutic options for drug overdose, and there's obviously need for more studies. Thank you very much.
Thank you very much. We'll welcome Professor Pérez Fernández to talk about the use of these technologies to prevent renal failure.
Hi, everybody. It's a pleasure to be here. Once again, for those who were not yesterday here listening to my first talk, I'm an ICU physician working in Belviche Hospital. We're part of a research group which we call Shiraki, that's Sears and Aki. We started like 10 years ago, and it's three big centers in the metropolitan area of Barcelona. Some of the people working in the studies are among the public, which is always nice to see. And I'm glad to present the results of our Shiraki 2 study, which I hope you enjoy. So my conflict of interest is, in part, we have the competitive grant from Baxter to perform this study, besides the public grant. And this was yesterday's dinner, so we drink a lot of French wine with this French band. So if I'm a little bit slow, that's fault of the Syrah. So basically, we ran over the physiopathology of cardiac surgery-associated AKI, which I think we all know, or at least the ones that are familiar with cardiac surgery patients. There's the activation of complement and all the inflammatory cascade when blood products get in contact with the strange surface, that's the cardiopulmonary bypass, plus the ischemia-reperfusion syndrome. So we're talking probably of a non-physiological response syndrome, which I want to separate a little bit from a septic inflammatory response syndrome. Of course, we have also the cardiac surgeon-associated AKI, with it's impossible to control. We know that cytokines are clearly related with the prognosis of our inflamed patients, not only in septic patients, but also in cardiac surgery-associated AKI, as we clearly see in this nice study in the Tribe-Aki group of the United States, where they show that AKI was clearly related with inflammatory mediator concentrations measured 6 hours after cardiac surgery. But not only AKI, but even mortality. So before we move on, let me just make two important questions. I know I'm probably not in the best place to, sorry, Claudio, what I'm going to say, but let's see. Are we really capable of removing effectively these mediators from the circulation of inflamed patients? In septic patients, I think it's not clear. It's not clear. That's the first question. And if we are really capable, is it really related with a better prognosis? And I think that we still don't have an answer for that question, at least in septic patients. I know there are believers in the room, so let's move on. We know that we have the technology to remove mediators, at least in animal model or in this nice study conducted by Mallard in a human plasma loop. During 2 hours, 2 liters moved with 3 devices, all doing absorption, CytoSorb, Thoramycin, and Oxiris. As you can see, the 3 of them are capable of removing these inflammatory mediators only by absorption. There was no ultrafiltration here. It was only absorption. We don't know the blood flow, but we know there were 2 liters, 2 hours. In my hospital, we have Oxiris. That's the device we had. So that's the device we employed to perform this study I'm going to show you. You know, Oxiris has an AN69 plus polytinamine, has absorption properties, not only cytokines, but also endotoxin. So the hypothesis of our study was performing absorption during cardiopulmonary bypass would trap cytokines, decreasing inflammatory response syndrome, and organ dysfunction. In this case, the organ dysfunction we want to measure was acute kidney injury. And first of all, we had to demonstrate that the technique was safe and feasible, of course. So that's why we ran the pilot study, Syracuse 01, in 2015. That was a very short study, 10 patients and 10 patients of control, and we performed 5 patients with only a little bit of ultrafiltration, no reposition at all, and 5 patients with CBBH, trying to see if there were some differences in terms of cytokine, only 5 patients in each group, so difficult to measure, but we didn't observe great differences. And probably the technique was easier only with SCOOF, with a little bit of ultrafiltration, with no reposition fluid. So that's what we selected after this safety study. How we performed the study was we connected, a little bit like ECMO. We had to put the machine inside the OR. There was no way to connect the membrane without the machine. As you know, we run between 200 and 300, sometimes even more, of blood flow connected after the pump, with positive pressure, back to the Prismaflex, and returning the blood to the venous reservoir, which you see here. To see with images, which is much better, you can see the machine running together with the cardiopulmonary bypass, and how we connected the lines coming out from the pump post a membrane, so just in case to be safe of air embolisms or that would be trapped after by the membrane. We obtained that blood here, the arterial line connected of the Prismaflex machine, and returning the blood with the venous line to the venous reservoir, which is this big chamber you see here. We had the Belbice clamp, of course. You have to explain the machine that he has to work with a rear pressure. For those who are used to ECMO, you know that this can happen, and the machine has to understand at the beginning. So sometimes they had to use this. We call it the Belbice clamp. And this is a machine running nicely with 350 ml minute with, as you can see, no reposition, but a little bit of ultrafiltration. You know that perfusionists sometimes they want to hemoconcentrate the patients during the cardiac surgery. We didn't say anything about that. It was just a decision of anesthesiology and perfusionists and cardiac surgeons, of course. So Syracuse 02 was granted by a public award from the ministry. That was 129,000 euros. But with that money, we didn't have enough to have a research fellow. There was a big study conducted in 2 big centers with a lot of patients. So we needed more money to have a research fellow. We applied for a competitive grant from Baxter, and that's where we obtained the study was feasible, basically. So the initial protocol of the study was a B-center randomized controlled trial, double arm, in non-emergent cardiac surgery patients, all with expected times over 60 minutes, excluding, of course, chronic kidney disease, advanced stage 4 and 5. And the endpoint of the study was basically absolute reduction of a cardiac surgery-associated AKI from 15 to 5% within the first 7 days, defining AKI by cardiac stage 1 or more, creatinine and urine output based. our population size, as you can see, was estimated in 322 patients, which was nice. We had another secondary endpoints, of course, cytokine, mechanical ventilation 3 days, vasopressor, ICU stay. But of course, things are not always like they look. So when we obtained the grant from Baxter, we sit down and we argued that maybe we should include only patients with high risk of AKI. That's where we changed our selection. The study had not been initiated yet. We changed the study, the selection criteria, and we included only patients with expected time over 90 minutes to get those who really were going to do, or who were really going to be in risk of AKI. Of course, that made us change the incidence of AKI expected from maintaining the absolute reduction of 10% from 25 to 15%. But for those who understand a little bit of statistics, as you can see, the population size was not changed. So that means that we have a higher incidence, but we didn't change the population size. That was our mistake, but that was basically to be feasible, to be able to recruit 222 patients in the time we had to perform the study. That means that we're probably underpowered. Machine running, as we explained before. This was the protocol of the study, blood flow, 200 and 300 ml minute, passing through the, with ultrafiltration flow left to the option of perfusionists, and returning to the venous reservoir. Machine running, and results. So I'm glad to present results because they have not been presented yet. I think they're quite solid, and we're now beginning to write it to be published, if possible. So basically, the study included finally 343 patients, with 174 patients in the standard group and 169 patients in the Osiris group. These are the characteristics of the patients, as you can see. Cardiopulmonary bypass time was high, expected, 124, 125, homogeneous, alliteration. I think it was randomized, it was controlled, so populations were comparable and homogeneous in all characteristics. And here's the main, the primary endpoint. So basically, we had a reduction of acute kidney injury within the first 7 days. Defined by stage 1 or more of KDIGO criteria, creatinine based and urine output based. And as you can see, the reduction was from nearly 40% on the control group to nearly 12% reduction, 28.4% in the interventional group. This is statistically significant. As you can see, the more age, the more risk of AKI, and it seems that intervention can protect. The same happens with cardiopulmonary bypass time. The more that the patient is connected to the pump, the more risk of AKI, and it seems also that the intervention can ameliorate the impact of the cardiopulmonary bypass time on AKI. And this one is a quite amazing slide, which we still are thinking about this, how clamp time seems to even have no effect or even a protective effect with the use of Osiris when the circuit is like running in a closed loop. No? It could be inspiration, ischemia perfusion after. We have to think about this. What about AKI? Because I said you that we had less AKI, it was significant, but what kind of AKI? Of course, you will be asking. Mostly stage 1, but we had also some stage 2 and some stage 3, and the reduction was in all 3 levels of AKI. So maybe we're the first ones to get to the moon, if you believe that man get to the moon. Or maybe not, because although we had less AKI, there was no impact on vasopressor or inotrope or mechanical ventilation 3 days. There was no impact on ICU stay. And of course, there was no impact on mortality, but we didn't expect to be differences in mortality. So maybe it's that the man didn't get to the moon really, and it was all cameras there. But we think that studies underpowered, of course. Probably with a bigger population, we will have had probably clinical effect in terms of ICU stay at least. And we can see, in terms of cytokines, we measured 60% of our population. The 40% was melted down when the fridge was disconnected from the wall, and we lost 130 samples or samples of patients. So we only were able to measure 60% of our patients, of our sample. We can see that there is a reduction in time 1, which is after the clamp. T2 is when the patient gets at ICU admission. T3 is 24 hours after ICU admission. It seems to be an effect in terms of interleukin-8 and TNF-alpha, and this effect is bigger if ultrafiltration is performed. Although ultrafiltration was only performed in 25% of the Oxiris group. And very few patients in the control group. We will have to see if we have intention to treat analysis per protocol analysis. So to end, let me try to explain the results of the study. This is how Gallegos think. I'm from Galicia, although I live in Barcelona. Gallegos, you never know if they go left or right. That's how we think, or we're famous about that. So maybe cytokines really decrease in the Oxiris arm, and this is associated with less cardiac surgery-associated AKI. That would be nice. It seems that it could be, but I think the study is underpowered. We should have more patients to demonstrate this because we don't have clinical impact in other endpoints like ICU stay, vasopressor support, etc. Maybe the Oxiris arm has less AKI, but there's no effect, real effect, because this effect on cytokines is not very, very impressive. So what are we really removing? Claudio, what are we removing here? Maybe there's no clinical effect despite cytokine differences. So maybe we have to change patient selection, get a really high risk phenotype of patients that they're really on risk, or maybe change the criteria endpoint and get severe AKI, moderate, and only stage 2 and 3, or maybe change the technique and do more ultrafiltration, not only absorption. Or maybe there's nothing, and I will just make wine with my children, which is one of my passions. So to finish, let me present you the team. People from Canruti, people from Belvice, people from San Pau, biochemistry department. A lot of people participating in this study. Was performed from 2016 to 2022 with COVID in the middle, and it was a very, very big job. Last, my email, if you have any questions, just write. I invite you to the symposium we're going to run on October in Hospital Belvice and dedicate this talk to Alberto Tejedor, which was a very good friend of ours, nephrologist, left us due to COVID, unfortunately, in 2020, and he was one of the normal speakers of this symposium. Thank you very much.
Professor Fernandez, thank you very much for your presentation. Again, about the timeline, we will then have a quick, short panel discussion. There is no better way to end this session as a lecture, as was the lecture from Claudio Ronco, and the way how he sees future about the blood purification. Thank you very much.
Thank you very much. Jose, I have to say that I prefer very much people who have a lot of uncertainties than people who have too many certainties. And the answer to your uncertainties is more research. So my father used to say, if you want to know something about the future, you better contribute to shape the future. And instead of going for science fiction presentations, etc., I will simply try to discuss with you a few areas where, let me see if the slide can move on, which it does not. Okay, now of course it's too much. And this is a fantastic way to kill a presentation, of course. So, These are the areas where I think we will need some innovation, and these are the areas where we are working on. Membrane, evolution, surface modification, non-thrombogenic materials and functionalization, miniaturization, nanotechnology, hybrid organs, water sparing techniques, sorbent technology, new indication, functionalized polymeric particles, and online biomonitoring. Let's speak for membranes for the moment. And as you know, there is a lot of science in polymer creation of membranes. And in fact, we are now mostly concentrating on two aspects about membranes. One is the density of pores, the other is the pore size distribution that affect the entire performance of the membrane in terms of hydraulic permeability and solute permeability. So if you increase pore density, definitely you will have an effect on small solute clearance. And in spite we are looking for larger solutes, we still want to remove small solutes when we do blood purification in our critically ill patient, especially if you move in a range of blood flow which is not tremendously high. The second point is to work on membrane pore size distribution, and you need to have a bell shape which is narrow and narrow to increase the average pore size and to block the cutoff value before albumin is leaked by the membrane. So we have different shapes in current membranes, and the most recent are the so-called high retention onset membrane, which seems to work very close to the glomerular basement membrane. And these membranes are also called medium cutoff, but I prefer to call it high retention because you see that the shape of the curve, and which is the red one, seems to describe better the similarity to the glomerular basement membrane. Our attempt is to achieve a pore size distribution which is even, and possibly that has such a high density to allow large removal of small and medium-sized molecules while albumin is retained. The other option is to add a bioproperty to a membrane. And in fact, we have several membranes today that undergo surface modification, improving biocompatibility, permeability, having no fouling effect. And one of the modifications of the N69 is the heparin absorption on the surface that allow to have a less thrombogenic surface. The other possibility is to functionalize the surface, creating, for example, less oxidation by adding vitamin E on the surface. And these are examples of things that are done today, but things that we should probably explore more in the future. How does nanotechnology offer new solutions? Well, moving from macro to micro to nano surface, you can probably help to create a kind of intelligent membrane. What does it mean for that? That you might have a multitude of pores that you can somehow functionalize with electrical charges, with characteristics, etc., and having a pore library that can be used in different conditions. Most of the time, engineers can respond to our question. The real thing is that we don't have the right questions. When they ask us, what do you want to remove? Very often we don't know. And that's why the engineers have to work with us, but they ask a specific question, and biology should have the answer to this. Concerning miniaturization, we have to be aware that in blood purification, you can miniaturize electronics, but you cannot miniaturize hydraulics. So we still are dealing with certain dimension which will never be the dimension of a pacemaker, because hydraulics is not compressible. This is just a device that we are testing in these days. It's a miniaturized portable ultrafiltration device, and it's a very nice something that may move the perspective of having big machines into small machines, probably near the patient or even on the body of the patient, not only for intensive care, but also for patients with ambulatory care, etc. And you see how much we try to work on safety, having all the characteristics of a big machine in a small machine. Many years ago, we have started our experiments on wearable artificial kidney, where in particular, we were able to achieve patients walking around while dialyzing and okay. The other option is indeed to try to combine biology with, let's say, plastic science and electronics in hybrid organs. For example, how much can we interfere on the structure of a membrane, putting cells into the composition of the final hybrid organ, maybe creating what we call the artificial tubulus. This is something we have been working, but anytime you add some biological components, you add a tremendous variability to the system, and this is a very complicated issue. Water sparing techniques, sorbent technology, functionalized polymeric particles. We have started just recently the science of sorbents and ion exchange resins. I was interested to see how much experiments have been done. I was the first involved in the study of what today is called Cytosorb, was originally called Betasorb, and we developed that in New York already in 1999 and 2000. And the original idea was to remove beta-2 microglobulin, but then subsequently we discovered the possibility to use this for acute patients. And the structure of these sorbents can now be somehow modified. It has been used in the past to regenerate dialysate. So to use very small amount of water in order to spare water, and this was the basics of the so-called RADI technique. RADI stays for circulation dialysis. And this was a combination of zirconium oxide, zirconium carbonate, zirconium phosphate, urease, activated carbon. So many, many different sorbents in one specific cartridge. Possibility is even to co-extrude membranes with sorbent particles or to have membranes embedded in a sorbent structure. These are experiments we are working a little bit on. And the coating of these membranes, of these sorbents, have made the sorbents today very biocompatible. So the safety issue has been somehow overcome. In the past, there were many reactions due to hemoperfusion. Today, this is really possible, and the resin is now very, very biocompatible. And we have different production of sorbents from the different companies that may be used for different purposes. One of the interesting things we are studying is to advise companies how to design these cartridges, because as we did in the past, we advised how to design filters and membranes. Now we are suggesting how to design, and we use isotherms, which are curves that are derived from industrial chemistry, and mass transfer zone, which is a specific performance measure on how a cartridge is designed. And then we have the possibility to test the porosity and probably also manage the porosity during production, so that not only we evaluate the composition with addition or subtraction of specific polymeric components, but also to analyze the structure as a result of different production modification, and again to use the pore density, pore size distribution curves to redefine what was in a sort of 2D dimension for membranes in a 3D dimension for beads and sorbents. And you see the reconstruction of these particles show that inside you may have different forces that can actually act to absorb materials. And we have to be aware of this because we can play with them. Now, we have different possibility to use hemoadsorption, together with CRRT or hemodialysis to plasma separate and then circulate the plasma through the device. Now, we have made in Rome last November a consensus conference on nomenclature and definition because we need to standardize our terminology. Otherwise, we are comparing apple and oranges, and this is very, very important. For example, if you use different type of sorbents on the plasma, you have to define the different characteristics of this. Now, I want to show you a little bit of a concept now that goes into the idea that we cannot say this works or does not work, because the idea is that when you have a septic patient, for example, you have time windows in which you may want to remove something specific like endotoxin or cytokines or other things. For example, this is a patient that we were very much interested because is paradigmatic. Admitted with fever, COVID-19, hyperinflamed, treated with hemoadsorption for 3 days, leading to hemodynamic stabilization, normalization of cytokine levels until extubation and improvement. What is, and Jose has mentioned this, what is that we're doing to this patient? So if you look at the effect, we remove cytokines, we decrease the amount of noradrenaline, we improve hemodynamics, but the most fascinating thing is that the cells of these patients have a completely different attitude after hemoadsorption. And we improve the monocyte function in terms of phagocytosis and TNF production. And these cells that were paralyzed in the septic patient starts again to present the antigen, start again to express HLA-DR on their surface. And there is an increased percent of monocytes expressing HLA-DR. So one of our approach to the future is to try to understand what kind of research we may need. But certainly, we need, as we did urea kinetics for hemodialysis, and we learn how to manage KT/V and dose for small molecules, we need to do biomonitoring to see what we're really doing with these therapies. And so far, we have not been good in selecting targets, in defining molecules to measure, and possibly to do measurement that is immediate while we're doing the treatment. It doesn't help me if I have a measure 30 days after. What are the open questions? Unwanted drug clearance, the timing, the dose, the duration, the anticoagulation, the flows, the cost as well. So there are several different aspects. But I think in the future, certainly, we will see more and more intelligent or bioactive membranes. Miniaturization and water-sparing techniques may represent targets for future blood purification therapies. Sorbents are probably the new frontier in blood purification, and we need to do more and more research. Biomonitoring and biomarker-guided treatment will require identification of target molecules, and we also need to identify the endophenotype that possibly benefit from extracorporeal blood purification therapies. We will never have the ultimate large randomized controlled trials because the design may be pleasing the editor of the New England Journal of Medicine, but most of the randomized trials are neutral or negative because they select a large population. We have to focus on specific population, and we have to identify this population. Now, so my father said, if you want to know the future, try to shape it. And I tell you, if you want to see the future, come to our meeting in Vicenza in June. Maybe you will have some answers. Thank you very much.